Today we're tackling a huge question in mental health. How do we stop depression from coming back? We're going to break down a major 2025 meta-analysis that looked at whether non-invasive brain stimulation, or NIBs, can actually prevent relapse after someone has started to recover.
And this is a really big deal. After a first recovery, about half of patients will relapse. But after a few episodes, that number skyrockets to a staggering 80%. This is a massive challenge, which is why finding treatments that actually last is so incredibly important.
All right, so here's our game plan. We'll start with the problem itself. Then we'll look at how this study was put together, because the methods are key. After that, we'll dive into the main results on relapse, get into the nitty-gritty of why different approaches worked differently, and then wrap it all up with what this means for clinical practice.
You know, medication is often the first line of defense. But for a lot of people, it either doesn't work well enough or the side effects are too much. That's why we desperately need other options. This is where non-invasive brain stimulation comes into the picture. Things like ECT and rTMS can be effective for getting people well, but the real million-dollar question is, can they keep people well?
Okay, so before we get to the exciting results, it's super important to understand how the researchers did this. The quality of the method is what makes us trust the conclusions. So let's take a quick look under the hood.
The authors used a system called the PICO framework to keep their search incredibly focused. The population was patients with depression. The intervention was maintenance inhibis for at least 3 months. This was then compared to other treatments like medication, and the main outcome they measured was the relapse rate. This framework just makes sure that all the studies they looked at were truly comparable.
And let me tell you, this process was exhaustive. They followed strict PRISMA guidelines, starting with over 11,000 potential studies. They screened thousands of them and ultimately boiled it all down to just 9 high-quality randomized controlled trials. The final analysis included 837 people, which gives these findings some serious statistical power.
All right, now for the main event. The first thing the researchers wanted to know is simple. Looking at the 6-month mark, did maintenance NIBS as a whole category work better than the control treatments at preventing relapse?
And this is where the story gets really interesting. Because when they lumped all the NIBS treatments together, the result was, well, inconclusive. You can see on this chart, the overall risk ratio looks promising, but the confidence interval crosses that 1.0 line. In statistics, that basically means the result isn't significant. So does NIBS not work for maintenance? Well, hold on. It's not that simple.
See, the key thing to remember is that NIBS isn't just one thing. It's a whole family of different treatments. Lumping them all together can hide what's really going on. The researchers knew this, so they did the smart thing. They broke it down into subgroups.
And as soon as they separated the ECT trials, a very clear picture started to form. It turns out that ECT combined with medication was effective, cutting the risk of relapse by about 36%. But, and this is a big but, using ECT by itself for maintenance showed no significant benefit. The analysis also points out that the effective combo therapy tended to use right unilateral placement, while the ineffective solo therapy used bitemporal. That's a really important detail.
So what about rTMS? Well, this was probably the biggest winner in the entire analysis. Repetitive transcranial magnetic stimulation, when used all on its own as a maintenance therapy, was significantly better than just medication for preventing relapse at 6 months. We're talking a risk ratio of 0.43, which is a very strong protective effect.
Okay, so these treatments work at 6 months. But does the protection actually last? That's the critical question, right? And the data here says a clear yes. For the strategies that worked, the benefit held strong not just at 9 months, but all the way out to a full year. That tells us we're looking at a durable, long-term effect, which is exactly the goal of maintenance therapy.
Looking at some of the other outcomes, the data showed that rTMS also more than doubled patient response rates compared to the controls. And just as important, people weren't dropping out of the NIBS treatments any more than the control groups, which suggests these therapies are generally well tolerated.
And let's talk about safety, because that's always a big concern with brain stimulation, especially cognitive side effects. The analysis looked at cognitive function scores and found no significant difference between the ECT groups and the medication groups. That's really reassuring and provides important data on the safety of these protocols.
So, after all that data, what's the bottom line? What does this all mean for doctors and patients trying to make decisions? Let's pull it all together and translate these findings into some practical guidance.
The analysis actually gives us some real clues about how to optimize these treatments.
For ECT, it looks like right unilateral placement is the way to go, along with a schedule that tapers down over time. And for RTMS, some of the newer protocols that use more intensive, clustered sessions might be a great way to boost effectiveness and make it easier for patients to stick with it.
Now, it's also really important to talk about what we don't know. The researchers looked, but they couldn't find a single eligible maintenance trial for other promising NIBS techniques like TDCS, MST, or TACS. This points to a huge gap in the research and shows us exactly where future studies need to focus.
And of course, no study is perfect, and the researchers are very upfront about the limitations here. A lot of the trials they included were pretty small. There was also a ton of variation in how the treatments were given, and not all the studies were blinded, which can introduce some bias. These are just important things to keep in the back of your mind.
But even with those limitations, the evidence from this deep dive gives us 3 very clear take-home messages. Number 1, ECT combined with medication is an effective strategy. Number 2, RTMS used by itself is also very effective. In fact, it showed the strongest effect here. And number 3, based on what we know right now, using ECT alone for maintenance therapy is not recommended.
So that leaves us with this final, powerful question. Now that we're getting a much clearer picture of which brain stimulation strategies work, how they work best, and in what combinations, how is this going to change the future of long-term depression care and bring us closer to a world where durable remission is the rule, not the exception?